Okay, so welcome to our webinar on uh, uh, what we can do to safely open the American economy. I am going to turn it over to our moderator, David Wallace-Wells, and thanks everyone for joining.
Thank you. Thanks for listening and watching, and just want to start by saying I'm thrilled to be talking with these three extremely distinguished, important thinkers, particularly on this issue, but really on any occasion would be thrilled to be doing it. This is an incredibly important report on an unbelievably critical set of issues that we face here in the US most acutely, although others around the world are facing it with similar urgency. I thought it might be useful before we start and get into the details of the plan and what it illustrates and what it tells us about what we need to do to safely move forward, for me to talk just a very little bit to sort of set the landscape by talking about the state of the disease as we know it. And I think, generally speaking, there is a sort of a vernacular understanding that the country has somewhat gotten the disease under control. I think that people have gotten a bit used to sheltering in place to the extent that they are, and have adjusted to a kind of a new normal. But the data really does tell a quite different story. Just about everywhere else in the world, countries that have taken the kinds of measures that the US has in terms of sheltering in place, lockdowns, et cetera, are seeing much more dramatic declines in the number of cases and the deaths from this disease than we are. We have achieved a kind of a rough plateau of daily death counts. It's at about roughly 2,000 a day, maybe a little less now. But this is an astonishingly high number, which we all would have been horrified to see projected into the future just a few months ago. And we probably should do what we can to continue to be horrified by it today and to take whatever policy measures we can to change that trajectory. Now, it's also the case that despite the fact that we are now, depending on where you are in the country, in some cases a month, in some cases 6 weeks into, practically speaking, a total lockdown, we have done very little as a country to prepare to reopen, which is now what we are about to start doing. The things that we would need to do, we're not testing nearly enough people. Yesterday, I think we tested about 260,000 people, and this report that we'll be talking about today calls for 5 million to start and scaling up to 20 million later in the summer. That means that we're at about 5% of the testing capacity that we would need to be at to safely open. We would probably also need, as this plan suggests, a number of contact tracers who help isolate cases and investigate where infections may have occurred. This plan cites 100,000 of them. Others call for higher numbers, and at the moment we have less than 10,000 working today. There are plans to put into place maybe as many as 30 or 40,000, but we're still talking about a fraction of what's necessary. And we're speaking in a week in which some quite bleak new forecasts have been put forward about the future shape of the disease in this country. Maybe most notably a report produced by the CDC and leaked, suggesting that as soon as June 1st, we would have as many as 3,000 deaths per day in the US. So about a 50% increase from where we are today. But I think it's notable that that's just a median projection, and this model, although we don't know the details of the model has basically undercounted enormously every data flow that we've had to this point. So in the last few weeks, when we've been, our death counts have been really shaped by the social distancing and sheltering in place guidelines. The data has fallen at or above the 75th percentile projection of this model. And for the few weeks before that, it was above the 97th percentile. The 75th percentile, if we project it just to June 1st, says that we will have as many as 7,500 deaths a day. And the 97th percentile at June 1st, which is not, it's less than a month away now, projects about 15,000. And of course, those trajectories move upward, which means that the summer, without aggressive intervention, could be considerably darker, scarier, and full of more health-based suffering, but also more, as a consequence, economic and other kinds of suffering than we've seen to this point. So at least as far as I see it, I think the data really bears this out. We have not turned a corner We do not have this under control. We have sort of frozen the situation for a period of time in order to allow us to introduce measures that could safely bring us back into something like normal life. But we haven't done nearly what we needed to do to make that reopening truly safe and possible. Now, this is a plan. I wrote a piece in last month that was called "There is no plan" about the federal government's total failure to prepare. I actually published a piece this morning that was, the headline was "There's still no plan." This is a plan. We're here to talk about a plan that is not yet, the law of the land or anything like it, but does sketch out in some real detail what would need to be done in order to bring us back some semblance of normal life while still protecting the American people from this horrifying disease. And I thought we should start the discussion with Danielle. I'd love it if you could sort of walk us through the sort of broad vision of what we're trying to do here, and then each of the particular components that are, as you see it, really necessary to secure this future.
Thank you, David. That was an excellent introduction and review of where we currently find ourselves. Excuse me. So I appreciate that setup. You said something very important. Toward the end of it, you remarked that we had basically frozen things in place in order to win ourselves time to build the tools that we need to suppress the disease while keeping the economy open. And you observed that although we did that freezing, we didn't actually do the building that should have gone along with it. I think that's exactly the right way to think about the situation that we are in. Back in February, there were 3 obvious policy paths available. We called them surrender, which was when you don't try at all to control the disease and you just let the deaths rack up. There was freeze, where you do freeze things, try to buy time, or in some models, expect that you will freeze repeatedly. This is also known as adaptive response, where you freeze things with social distancing to reduce the transmission of disease. And then when things fall down, you can open up again, but you also know that there will be another surge and you're going to have to repeat that application of freezing. That's a very expensive model. The first model, surrender, is very expensive, so is the freeze model. The third pathway that was available was precisely using that initial freeze to mobilize and transition the economy to build the tools needed for disease control. And the tools needed for disease control, so to your question, David, are massively scaled up testing, contact tracing, and supported isolation. So folks have known for a long time that testing and quarantine can control the disease, help control a pandemic or infectious diseases. But the point of the current disease that we face, or the challenge with it, is that there are some huge number of asymptomatic individuals. And so if you use a model where all you're doing is for every person that you test as a patient, sort of finding their contacts and quarantining them, you're not actually moving aggressively enough to break the chains of transmission of the disease. It's really important also to identify asymptomatic or pre-symptomatic carriers of the disease and find all of their contacts as well, and keep following through the chains of transmission in order to leave you at such a point where you're not picking up positives anymore. And it's that kind of higher level, more aggressive level of contact tracing and testing that we actually need in order to suppress COVID-19. So our estimates of the requirement of 5 million tests a day are based on that very aggressive approach to suppressing the disease. We modeled based on success in Asian countries and the level of testing that they've used to contain and suppress the disease. And typically you'll see that in their testing, their tests only return 3% rate of positives. That tells you when you're testing enough. You're testing so broadly that you really know you're getting all those positives. Our testing rate is still returning positivity rates of somewhere between 15 and 20%. So that tells you sort of how far off the targets are we need to be for our testing regimes. So one of the challenges with building this kind of testing and tracing regime that we need to actually suppress the disease while keeping the economy open has been that for months, for all of February, all of March, and most of April, the CDC was giving guidance for testing that only prioritized testing symptomatic patients. So the very good news is that as of April 27th, the CDC changed its guidance, and there's now a second priority on testing asymptomatic individuals. So as of April 27th, the CDC now supports broad-scale testing and tracing regimes. The challenge, therefore, at this point is to figure out how to build the infrastructure to deliver throughout the country. And it's important to recognize the needs are different region to region according to levels of disease prevalence. And this is probably one of the hardest things. So a place like New York needs a massively higher supply of tests and tracing personnel than does a place like Texas. And so in order to move the picture forward of what we need and to achieve that aggregate 5 million tests a day total, we really need a regionally differentiated picture, and we need to build in the sort of infrastructure investments that can support that. So for example, in areas with lower population density, we need a higher distribution of sort of Abbott style point of care machines. But in areas of high population density, what we really need to invest in is a certain number of mega labs that can process on the order of 1 million tests a day, as the sort of densely populated urban areas with high prevalence are able to ramp up test collection, sample collection, and so forth over the coming months. So the important message here is that for the first time, the CDC actually provides a framework where we can actually build out a program of testing, tracing, and supported isolation. And now there's a huge amount of work to do to help state and local decision makers actually flesh out the precise programs they should use to achieve those targets in their locales. An important piece of achieving that, I think, is really, in some sense, sort of stiffening people's motivation to achieve this. And the numbers that David pointed to about sort of failures of cases to decline, growth of cases in various places and so forth should be the red alert, a warning sign pointing to the importance of engaging local leaders everywhere in setting these most ambitious targets for a testing, tracing, and supported isolation protocol. So that's the picture of where we are. I'm happy to say more, David, if there's sort of specific pieces of this that I didn't directly address, but I'll leave it there for now.
Well, one very quick follow-up is, as it compares to some other plans that have been put forward by similar bodies, this one, as far as I understand, has the sort of highest targets for daily testing. How do you get to those numbers precisely, and how does your proposal compare to some of the others?
Sure. So our proposal was developed out of an effort to target achieving a reproduction rate for the virus in the near term of 0.75. So people will have heard a lot about this reproduction number, right? If each person infects more than one other person, then the R is above 1 and you get exponential growth of the disease. So to decelerate the disease, you need R below 1. We targeted R of 0.75 to achieve a steady downward deceleration of the disease across the country. So that's a feature of where our numbers come from. But the other important thing to say is, how do those numbers actually connect to a testing and tracing protocol? And that's where what we've really done is sort of innovated on the typical tools of public health. So the typical tools of public health would be, again, that you'd find a COVID positive individual, you'd identify their contacts, you'd quarantine all their contacts for the 14 days or the relevant period, and you'd move on to another COVID positive individual who came up completely independently. You wouldn't test those contacts from your first COVID positive person and follow the chain of transmission. So the reason our testing number is so much higher is because we are recommending following that whole chain of transmission from every first sort of seed of a COVID positive person that you find. And again, the reason for doing that is because of the high percentage of asymptomatic and pre-symptomatic people. 25 to 40% of infectious people who are able to infect others don't have symptoms. That is the biggest challenge that we face with regard to this disease. And it's because of that feature of it that one needs the more aggressive approach to really following the whole chain of transmission and finding even all the asymptomatic COVID positive people. So that's why our numbers are larger than others. And our view is that if you're not that aggressive about following the chain of transmission, you won't actually be able to decelerate the disease. And to some extent, that's what we're seeing as we see this sort of flattening at the plateau and not a deceleration. I think that's partly because people are keying off that conventional methodology that stops short of following the whole chain of transmission.
Thank you. I'd like to turn to Anne-Marie, but to build off of a few things that Danielle said. This is, to some degree, conventional wisdom in how to fight a disease like this. We saw behavior along these lines in Asia fighting SARS and MERS. And if you would put it as a sort of challenge to someone, how can we map out a response in America, say in January, when we were first worrying about the possibility of the disease arriving here, probably something like this plan would have been what was put forward. Certainly, we started seeing the results of some more effective programs like it around the world, starting in February and into March. And each of those months, I think, marks a really dramatic, from my perspective, failure of American leadership to really get this going, especially at the federal level, though there have been some more encouraging initiatives at state and local levels. How do you see that failure? Why are we here now in May talking about these plans at this level, in this kind of a context, rather than talking about a program that has been put forward by a federal task force, organizing information, instituting mass testing, and paying for it through federal means? Why are we where we are now, rather than where so many other countries in the world are?
Well, I think the answer is in part a failure of leadership and in part a failure of imagination and belief. The easier story is to compare the US federal government's response in January with the South Korean response. At the end of January, the South Korean government pulled together the heads of medical supply and pharmaceutical companies at the end of January, when they had only a few cases and the United States had only a few cases, and said, we are going to need a massive ramp up in testing, and got them going that early, whereas we still have not done that at a national level. We have certainly increased our capacity for testing, but not nearly enough. Now, some of that is because South Korea had a much more intense experience with SARS. Taiwan, which has also done a tremendous amount of testing, had SARS as well. So these are countries that are learning from experience. But it is also true that there were lots of reasons that the president did not want to accept the full scope of what was happening. And we had dismantled the health security part of the National Security Council, which is something that President Obama set up after the Ebola, excuse me, the Ebola crisis. So we were not prepared, and we didn't take it seriously enough. And critically, we have not wanted to respond through the federal government, mobilizing the country on a wartime footing, using a pandemic testing board like the Defense Production Board, which the president's used, but only to keep, not to actually mobilize supply chains and commandeer companies to do what we need to do. I do think, as Danielle said, the CDC has changed its testing guidance. That is important. The president did issue a national strategy that argued for more testing, not enough, but also referenced the innovation pathway that could get us to many more tests. And that's where I'd say the other failure is a failure of imagination. You know, we are here at the Breakthrough Institute, and there is a possibility for many breakthroughs. This opportunity to say, we are massively going to ramp up testing, instead of saying we can't, why don't we say, of course we can, and we can do it both through building capacity with existing testing, but much more important, let's innovate. And we're seeing extraordinary innovation, and let's use this to build a new community health infrastructure that will not only protect us against this virus and the return of this virus in various forms, but the next virus and many other kinds of disasters. So really, in the end, to get us there, it isn't just a federal leadership and a state and local leadership that are responding. It's getting ahead of the curve and imagining how we turn this crisis into the kind of transformation we need in all sorts of different areas.
And then thinking about it in this sort of acute short-term, like what would a successful next month look like? If we were hoping to see something like this level of testing and tracing and isolation achieved, what would be the encouraging signs from the government that we haven't seen to this point? What should we be looking for, and what should we be pushing for? How do you see success defined over the next month or so?
Well, the best thing that could happen, certainly from the federal government, would be to say we need to test at a much, much higher level, to accept that we can do it and that we need to do it. And indeed for Congress to keep appropriating funds that would allow us to do that. But I think at this point, real success in the next month, given where we are, would equally come from governors and mayors. And our group will be releasing a new report next week that offers guidance to state, local, and tribal authorities, really much more nuanced guidance that says, based on the prevalence of the disease, as far as we can tell right now, and based on the density of your population, here's our guidance. And it's going to be a moment where all of us, all the local and tribal and state authorities have to step up, because we can't wait on the federal government at this point.
So Ted, turning to you for a second, that's not what we're doing right now. Most states, localities, tribal authorities are moving to the degree that they are, at the speed they are. I would guess, you know, without having satisfied a lot of the requirements that you guys would hope that they would have satisfied before opening up. What is the danger here? What are we likely to see, and what should we be thinking about in terms of the downside of reopening too soon?
Yeah, thanks, David. I mean, I think we are in the process of embarking on a, you know, essentially a kind of an effort to try to normalize, under the best case, 150 to 200,000 deaths, and convince people to go back to work and normal economic activity. I would suggest this is not going to work. And that the sort of idea that you can just announce the economy reopened and sort of things will get back to sort of normal is basically delusional. That, you know, I think, as you pointed out in your very excellent article the other day, the numbers, you know, we've kind of really achieved just a plateau through quite draconian sheltering in place in most parts of the country, because there are still a whole lot of essential activities and essential parts of the economy and the healthcare system that need to keep functioning. We actually, with, you know, radically less testing than we need even now, that means that the best we've been able to do is to sort of get to maybe a peak for the time being in daily deaths, but not really drive that down. And as you then start to kind of actually loosen these restrictions and open up the economy, that is likely to increase. So under those conditions, it is quite understandable, and you know, you can look at the survey data, the polling data, that most people are like, they want to continue to shelter in place. They don't want to go back and put themselves and their families at risk. So I think that, you know, on the current course, what we're likely to see is a sort of partial temporary reopening, a big spike in cases and deaths, and then we're going to start shutting this stuff down. And even if we don't actually shut it down, people are just, they're not going to go back to work. They're not going to go back to restaurants. They're not going to go back to the activities that, you know, a sort of normally functioning economy requires. So I think that's where we're at now. You know, I think, as Anne Marie noted, and I think it's correct, you know, even if the federal government really got its act together, and I'd be interested, you know, in hearing from both Anne Marie and Danielle about sort of what they know about what's being done with the $25 billion that Congress has already appropriated for testing. But even if we really got serious and started sort of seeing the leadership we need at the federal level, it will take time. And so I think the sort of main event and most of the action right now is happening at the state and local level. You know, I feel quite lucky to live in the San Francisco Bay Area, where we implemented the first real shelter-in-place orders in the country across the kind of core 6 counties of the Bay Area here. And it's been very interesting watching sort of how those counties, with really good public health leadership and political leadership listening to the public health expertise that we have here, sort of starting to put in place the necessary conditions to reopen. So I was just reading this morning that San Francisco, Santa Clara, a whole set of these counties are now actually kind of like literally going, how many contact tracers do we need to hire in the next couple of weeks to be able to actually trace contacts? We're starting to get our testing scaled up, although even here it's quite lumpy. Some counties doing better than others. So I think I think we're going to kind of start to see what works and what doesn't work, and what it looks like for particular places to actually sort of reopen their economies in ways that are sustainable, and also what it looks like when we do it and it's not sustainable. But certainly my view is that without sort of something that approaches the roadmap that sort of Danielle led and Anne-Marie and I both were co-authors on, we are, these efforts to sort of restart the economy are not going to work. Not only is the sort of caseload not going to decline, but I think there's going to be another shoe to drop here. I think that if you look at the markets right now, I think there is still a kind of assumption that the economy is going to come back in the second half of this year. And if we don't actually sort of scale a real testing and tracing regime, that is just not going to happen. And I think some point in the next couple of months, the markets are going to come to terms with that. So I think there's going to be another big economic sort of shoe that's going to drop here in the next few months.
As if the 33 million people who have
yeah, exactly.
So I just wanted to say to everybody who's listening, we are going to be doing a segment of Q&A from you in probably about 15 minutes or so. And if you want to drop your questions into the Q&A side chat, we'll be drawing from there. So please do that over the next little while, and I'll be drawing from those when we get to that portion of the conversation. Ted, I wanted to ask one follow-up of you, which is, you mentioned at the end there that there actually may be some wisdom and some value in the kind of disaggregated, federalized response to this, because we will start to see different approaches. We will be able to measure which things work and theoretically at least learn from best practices over the next few months. One big question I have is whether shelter in place was appropriate when it was first put forward. If at the moment we've basically reduced nationally the R0 number to just about 1, maybe a little below 1, but basically just at 1, so that the size of the disease is roughly staying flat. And we're, in this report, you're proposing that we use mass testing, tracing, and isolation to get it down to 0.75. That suggests that sheltering in place, while in some ways has been presented as a kind of a last-ditch backstop effort, is also not even as effective as the kinds of things we could have been doing with intervening or dampening the economy nearly as much as we have. Now, of course, there are reasons, practical reasons, political reasons why we weren't ready to institute this kind of a program, say back in January or February. But in theory, would it have been better to implement a testing regime before shelter in place, or does shelter in place have a use beyond the simple R0 number?
Yeah, I mean, I think Anne-Marie and Danielle may have something to say about that too, but I'll just say, I kind of really got into this out of a series of conversations I had with Paul Romer, who's a senior fellow at Breakthrough. And Paul, obviously was really one of the first people who kind of just came out very publicly and said, if you want to sort of save the economy and get us through this thing with a sort of minimizing the human costs, you need to massively scale testing, and you need to do it right now. And as costly as that might be, it's going to be a lot less costly than what's going to happen to the economy if we don't do it. Paul was, obviously, absolutely right about that. And yeah, I mean, your point is, if we had been in the position to do 5 or 20 million tests a day in early March, I think we could have avoided the depth of the economic impact that we've experienced and the need to sort of radically shelter in place at the levels that we have. So yeah, it has been a kind of last last ditch sort of in the face of having any other capacity to control the spread of the disease and its capacity to overwhelm the healthcare system. That's what we did, but it wasn't necessary. You know, there were other ways we could have kind of dealt with this with a lot less impact but it would have required a lot more foresight and leadership than we've had.
And this is maybe too general a question given how different different parts of the country are in their preparation. But is it fair to assume that each of you would like to see the existing shelter-in-place guidelines continue at least until such a testing regime could be implemented? Or do you think it's safe to continue to start to have some limiting reopening as we ramp up our testing capacity? Maybe Danielle, you could answer that first.
Sure, happy to speak to that. So let me actually put that question together with the question about what we needed to do in the first moment, because two things pertain in the first moment that no longer pertain. In the first moment, we just did not know the situation. We didn't have enough data to know exactly where the disease was and how quickly it was spreading, in addition to the fact that we didn't have the resources to build up a testing and tracing supported isolation regime. So that absence of usable data was a really key part of our vulnerability as well, it needs to be said out loud. And so that's why we really kind of did need quite broad across the board shutdowns. That's the kind of tool that you should really only use as a last-ditch temporary measure. And so we should have, the moment we started using them, have been building the alternative tool. So those things go together. But so now we are at a place where we have much more usable data. And so in that regard, there's no sense in which we need just sort of nationwide stay-at-home order any longer. And so one of the things that we've been working to do is to differentiate three categories of zone, basically green zones, yellow zones, and red zones. Green zones are places where the prevalence is very, very close to zero, and they should be open, and there's no question about that. They are the smallest percentage of the country, it must be said, but that's where they are. And then there are yellow zones, where the prevalence is below 1%, and a full-scale TTSI regime is absolutely within people's reach. They can do it. And from our point of view, yes, it would be better if they continued to stay at home until they actually had that in place, because stay at home also decelerates the disease. If you abandon stay at home, you just keep making the problem harder for yourself. Then you need more tests, right? So it's sort of like, if you don't do stay at home, you end up with a moving target for the quantity of tests that you need. So that's why what you really want to do is until you have the testing capacity that you need for the prevalence that you're at, you want to maintain stay at home so you can come out of stay at home and continue on that downward decline that stay at home has started for you. So that's the yellow part of the country. Again, we would recommend that people stay at home until they have that testing capacity in place, but we also recognize the reality of the fact that that's not what people are doing. So that doesn't change their need to build the testing, tracing, and supported isolation programs. It just means they're going to have to aim for higher targets. There's a little bit of, if you invest late, you have to invest more. That's sort of the nature of the dynamic here. And then in red zones, so that's New York City, that's New Jersey, that's Massachusetts. There we very firmly recommend maintaining stay-at-home orders. The prevalence is above 1%. In the New York, New Jersey area, as many as 1 in 30 people are now infectious. So that gives you a sort of sense of the scale of the disease. And basically, yes, in that context, the gap between our current testing capacity and what we need to decelerate the disease is so large that those regions definitely need to use stay-at-home as an additional tool of disease deceleration.
So you talked a bit about how different parts of the country are facing different challenges and are in different levels of preparation. But I wonder if it's also worth thinking about the different ways in which different communities or even individuals within particular regions are at risk. So, you know, we have healthcare workers, we have other people who've been described as essential workers who are experience much more exposure than, you know, the sort of bulk of the population that are unable to or are not actually staying at home but are doing the essential work that they need to do. And then of course there are differential vulnerabilities across you know, the age spectrum, for instance. Should we think about, especially in a period when we have something below the threshold of say 5 million tests a day, should we think about targeting either the most vulnerable populations or the most exposed populations, or does this need to be a sort of universal approach that doesn't discriminate in that way?
So we do recommend targeting of testing. And so going back to our roadmap from April 20th, our view is that the first order of business is to ensure that people who are active in the essential workforce are fully integrated into testing regimes. And there's two kinds of way to integrate people into testing regimes. There's this sort of contact tracing method that we've been talking about, which is where, for every seed, you're really following that chain of transmission. And so we really ought to be prioritizing sort of finding COVID positive individuals in the essential workforce, even if they're asymptomatic, and then following chains of transmission. Excuse me. There's another thing that you can also do involving some amount of routine testing. So the White House is an example where they're testing the staff in the White House on a weekly basis. It's a critical context. It's a national security context. It makes sense to think of both national security contexts and high vulnerability contexts as places where, as critical contexts where routine testing makes sense. In some cases, you can do pooled testing where you take a whole bunch of samples and you test them together in one go. And then you only retest people or you quarantine the whole batch if it comes out positive. That's a way of achieving efficiencies with regard to the number of tests that you need. And yes, we should be working on routine testing, including some elements of pooled testing for the essential workforce and elder care facilities, incarcerated populations, meat packing plants, other kinds of assembly line conditions. Excuse me.
Anne-Marie, I wanted to put to you the question that, that Ted asked of you and Danielle earlier, which is, what do we know about what is happening today? Taking in mind this sort of broad context that you've laid out and that you've all laid out in this report, what we really need to do to feel safe moving forward. What's happening at the moment? How should we judge that? And what should we expect to see, do you think, over the next month or 6 weeks?
I'm going to let Danielle answer the part about how the money that Congress has already appropriated, the $25 billion, is being spent. But before she does, I will say we are seeing a real convergence in expert opinion on testing, tracing, and supported isolation. It's been very interesting just in the last 2 to 3 weeks to see various expert reports, economists, as well as public health authorities coming together around this approach. There are differences in terms of the exact numbers of tests that we need, and Danielle's explained why it is that our numbers are higher than other people's numbers, and we want to see us open the economy and stay open. And to do that, we think we need this higher number. But many, many people, including, again, the CDC has changed its guidance, have come to realize this is the only way forward. And again, if you read newspaper editorials like the Washington Post and again, newspaper editorials from across the country, so not just in the most affected areas, are converging. That's, I think, very important. It's also true that governors are realizing they need a certain amount of tests, but not just political authorities. And this is critical. Christine Paxson, the president of Brown, wrote an op-ed 10 days ago saying the colleges really have to reopen, colleges and universities, that this is critical for the health of the higher education system to begin with, which is a big part of the economy, but also for students, that what they get in even a modified campus environment is really critical to their education. Online is only part of it. And I can say, as the mother of a college freshman who is now taking his classes on the 3rd floor, I could not agree more. But here's the thing. Christine Paxson, President Paxson, who is herself a health economist, says, I'm going to need roughly 15,000 tests to be able to reopen Brown University. Lots of different employers are going to reach that same view, university presidents, leaders of major organizations. This is a big part of where we need to go. It has to be done, yes, by state authorities, by local and tribal authorities to plan, and we're trying to give them guidance to help them plan, but the demand for these tests has to also come from individual leaders who recognize this is the only way that I can reopen, even as I build toward a new normal. In other words, lots of social distancing, all sorts of other precautions to control the disease, but it's the only way to go forward to have a functioning economy and society, which we can't just shut down until there's a vaccine.
Well, to that point, Danielle, yeah, I wonder if in talking about the sort of appropriated funds, you might also touch on, given that there is this demand and it will grow, presumably, what can we do, what do we need to do to supply that amount of testing?
So, great, and I think there is a link between these two questions. The appropriated funds are under the authority of the Department of Health and Human Services, and as of yet, there is not a lot of clarity about exactly how they're going to spend them. There's an expectation that some of that will be spent on purchase of point-of-care machines and distribution, particularly to rural areas and other kinds of underserved areas. They've done that previously. There was a significant investment in point-of-care machines for tribal health authorities, for example. So that's a piece. There's also a need for investment and high throughput processing in labs, academic and commercial labs. And so that may well be a piece of how the funds get invested. I hope it will be. It's a critical part. But exactly, you have the question that you have precisely because there's not a plan, right? Or at least there's not a public plan. And that makes it very hard for us to see how all these pieces are coming together, how funds are getting allocated to states for purchase of test kits and test supplies and things like that. So basically, I think what I see happening is what Anne-Marie describes, namely there'll be increased demand coming from county level, municipal level leaders, filtering up to state level leaders. And then there is a need to sort of close the link between kind of congressional appropriations and those needs. And I think the way the link gets closed most efficiently at this point is if all the regional compacts of states that we are seeing take their organizational structure to the next level and sort of formally establish themselves as interstate compacts, which give them sort of access to kind of procurement capacity and other kinds of organizational capacity that could activate the supply chain. So I think that's the missing piece that I hope we'll see in the next week to 2 weeks, basically, that the regional compacts form themselves into effective actors able to close the link between the appropriations and the demand side of the question.
So we have just a few minutes left before we move to the sort of audience Q&A. And I wanted to ask, we've talked a fair amount about the sort of short and medium term and what we really want to be aiming for, say, over the next month or 3 months in order to start to really seriously feel comfortable reopening the economy. How long do you all see that regime lasting? If we're needing 20 million tests a day to feel comfortable, how long, and even if we get to that point, how long do you think that we will be continuing to conduct 20 million tests a day? And how long do we think that'll be necessary? How do you see the sort of long-term timeline of this fight? And how do you see it resolving?
So let me just, if you don't mind, clarify the target and then also answer your question. So when we were projecting to the 20 million a day, that was also based on a concern that the country wouldn't be able to build up contact tracing personnel resources to a sufficient level. So the number that we need is 5 million a day if we can achieve robust contact tracing, and then it's 20 million a day if we can't. So the weaker your contact tracing infrastructure, the more tests you need. So in that regard, insofar as I think there is a really strong, robust public conversation now about contact tracing, we can focus on the 5 million a day target, but know that as we focus on that, we're building up contact tracing personnel as well. That's the important thing. So then in terms of what we need, as we see it, there's a sort of a peak period, sort of surge effort that lasts 2 to 3 months. And the point of that effort is to bring everybody into a place where the disease is steadily decelerating. And then the amount of tests that you need starts to also decline over time. So we really are not talking about maintaining 5 million tests a day for the next 18 months or 2 years, for example, until there's a vaccine. We're talking about finishing the job of getting ourselves to a steady deceleration place, where then a lower level of testing, still much higher than we started this crisis with, but not that full 5 million a day level, can put us in a maintenance place continuously throughout until we get a vaccine.
And when do you all think there will be a vaccine? And maybe foolish to make predictions, but are we talking about 6 months? Are we talking about 18 months? Are we talking about 36 months? Or are we talking about we can't make any firm plans because so much is ambiguous?
I think it's the last myself. I mean, I think an awful lot of people want it in 6 months. And, there's intense desire for it in 6 months, particularly actually on the part of the White House, for whom it would transform the election, right? So in that regard, they've recently said they're sort of shifting their focus to accelerating the development of a vaccine. And I believe that they will invest in that, because success on that front would be a huge win for the country and for the administration. The science of it is just really hard. And so I think that's where the ambiguity comes in. So scientists will both point out that we've never yet achieved a vaccine for a coronavirus. It's different from achieving a vaccine for influenza virus, for instance. So people will say that, but then scientists will also say, on the other hand, that they've never worked as hard before on trying to come up with a vaccine for a coronavirus. So the parameters of possibility sort of lie between those two things.
And I would just add that, just as a general principle, I mean, given how much uncertainty there is in how quickly we can develop a vaccine, how quickly we can scale it, to what degree the virus is going to mutate in ways that make a vaccine more or less effective, we literally don't know. It could be 6 months, it could be 2 years. There's certainly a non-zero possibility, it could be never. And so you have got to have a plan and a strategy that is just robust to that uncertainty. You scale the testing, you get it under control, you then kind of maintain the capability to do maintenance testing sufficient to sort of keep the disease under control so that you can get back to normal life. And I think it is extraordinarily unwise to kind of bet the entire American economy and hundreds and thousands, or even potentially more than that, American deaths on the bet that a vaccine is going to materialize quickly. We just don't know.
I think I'll move to, since we have about 10 minutes left, move to questions from those listening and watching. One is from Chris Ulick, I think is how you pronounce his name, about sort of relative risk of activities like walking outside and sunbathing and being in parks. And I do think it's interesting in the sense that we've talked a lot about the slowness, the sort of failures of the federal government to coordinate mass testing and that sort of thing. But it's also the case that there hasn't been a sort of single presentation of best practices for individuals to learn from either. And so people are making decisions on their own based on information they find here and there in media from local leaders. But there has been, as far as I can tell, a quite disorganized presentation of what we know. And I wonder, first of all, how important you all think that failure has been, whether, presumably it would be better if there was a single clearinghouse, but also what you would like to see individuals do, how you would like to see them model their own behavior and do what they can to reduce transmission in their own lives, independent of testing capacities.
So I think this is super important. And in the report that we're releasing next week, as Anne-Marie mentioned, we do have a section on individual risk and how should individuals think about what they should be doing, precisely to fill that hole that you just described. Again, it's important to differentiate. And this is where I think it's been hard, partly because you can't actually give one answer to that question for the entire country. So there really is a difference between the answer for people who find themselves in what we call green zones, yellow zones, and red zones. So green zones, life can go on more or less in a pre-pandemic way. And again, that's the smaller part of the country. About 19 million people currently live in green zones. Yellow zones are the hardest spot. I'll come back to that in a second. Red zones are where basically people should stay under stay-at-home orders or advisories, or choose that for themselves if the regime changes because the danger is sufficiently high. So yellow zones, if the testing is in place, the yellow zones is again where prevalence is below 1% of active infection. If there is an aggressive testing regime in place, then people who are not high vulnerability can reasonably reboot their ordinary economic activities wearing masks with good practices of hand washing, good practices of ongoing social distancing and things like that, but nonetheless more or less resume normal activities. People who are in high risk categories, even in yellow zones, probably want to continue sheltering at home. So that's where we really do have an issue of quite different kinds of vulnerability. And that's one of the hardest problems in all of this. So that's a hard one too, because there are age issues, but there's also underlying health status. So the question of who's vulnerable sort of really yields a population that is fully woven into the rest of our population. So you can't really kind of pull out the high vulnerability group and just sort of achieve a special protection for that group. So it's a set of hard choices, but I think, so that's why from our point of view too, having better usable data for everybody so you can really tell, am I in a sort of green zone, am I in a yellow zone, am I in a red zone, is critical, because people have to be able to make those individual risk assessments.
And David, I would just add one other thing, because I think Chris's question, one of the point was sort of, to what degree is a bunch of this stuff kind of virtue signaling? And I will say that, I am generally, as many people probably listening know, a huge critic of virtue signaling in all sorts of contexts. I think it's very, very destructive. In this case, I think virtue signaling is good in most cases, because what we're talking about here is a kind of social proof that goes on. That when people wear masks, when they do it in public, even when even at the very beginning of this thing, I remember, when I first started stopping shaking hands in meetings. And first of all, how hard it was to do. It was such second nature to shake someone's hand. And the third thing is how hard it really is to do when someone sticks their hand in your face and you're like, sorry, I'm not going to shake your hand. Which in every other context is just a rude, to hell with you, you stuck up bastard or whatever. And in this case, it was necessary. And so I think around, whether you're in a green, a yellow, or a red zone, I think that there's a huge amount of social proof here that is really, really important. And it's almost more important than kind of protecting yourself from spreading the disease or contracting the disease, is just actually sort of demonstrating and showing your willingness to kind of engage in these practices on a daily basis. That are really critical to sort of beyond any of the public policy measures that are being put in place, and the legal requirements or testing or anything else are necessary to slow the disease. So that is maybe the first time I've ever argued for virtue signaling, and I think it's actually quite healthy behavior right now in this context.
So the last question I'm going to field is from Matthew Lewis, who asked whether this crisis was a kind of illustration of the Reaganite principle that government is the problem. I mean, I would say personally, it seems to me that the opposite conclusion is more pertinent, which is to say that there are a lot of things we really need government to do that other areas of our society can't. But I think in general, the theme is a quite important one, which is to say, touching on something that you mentioned earlier, Anne-Marie, about the way that we can use this to build up a different relationship to community health generally. How do you all see longer term impacts of this, particularly shaping the relationship of Americans to the public sector, what we expect from government? Is it possible that we will find ourselves in a much more interventionist political mood, much more supportive of government action over the next decade or two as a result of this crisis? Or are we likely to stay in the same quite confined, sort of tribalized bubbles in which those on the left have one set of ideas about this and those on the right have a very different one? How do you each see it? Maybe Anne-Marie, start with you.
So I would say that we do need a different relationship to government, and in part that it's not a question of big government versus small government. It's about smart government, and it's about moving to government that is really ready for the digital era. This crisis is what I've called a time machine to the future. Many of us have been writing about the dramatic changes that had to come in higher education simply because the financial models of most of our institutions of higher education aren't sustainable. You can't just keep raising tuition and funding that through student debt. We knew that. We knew that the future of work was coming, that in a very different way, that a lot of jobs were going to be automated and a lot of people were going to be out of work. We didn't anticipate it coming so fast and in such a concentrated way, but many of the changes we're going to see, we knew were coming. Similarly, in terms of the way we even use space, and the fact that many of us will not be going back to our offices in using them the same way. And indeed, you have the head of Barclays already saying, well, maybe we don't need headquarters at all. I don't think that's true, but I think we're heading for massive transformation. Government has an absolutely essential role to play here. It has to build not a social safety net, but a social foundation. People need the ability to learn new skills, to move to different kinds of jobs, to participate in a fully digital economy. And again, that doesn't mean no physical interaction, not far from it, but quite differently. Just as we need a different health infrastructure. Universal health care is the beginning, but healthcare that can be delivered much more effectively at a local level is essential, not just for COVID, but for obesity, for diabetes, for all the many different kinds of chronic diseases we've been grappling with that impose such a cost on American business and on American society. So I see this as a way, if we can get the response to COVID right, that is the beginning of going forward with a different role for government. And I'd say equally in partnership with both business and a lot of civic groups that will solve a whole set of challenges, or at least tackle them. They won't solve them, but tackle them in a way that is much more appropriate and necessary for the era we find ourselves in.
Danielle and Ted, do you have any last thoughts to offer?
I would just offer a brief addendum, perhaps, which is that I think I would say that the problem or the question is perhaps less one of government than of governance, and the question of whether we can collectively rebuild our understanding of what governance consists of. Its etymology comes from the Greek word for steering a ship. We don't have any ship steering going on these days. And we don't really understand what it means to steer a ship, because to steer a ship, you actually have to also build and cultivate a conception of common purpose. Our politics has lost the capacity to deliver that. And that, from my point of view, is the single most important question that we face.
Yeah, I'll just add slow with close with just one. I think that Reaganism, my view, and folks who've read some of my stuff kind of will be familiar with this. I think Reaganism is a symptom of a sort of broader loss of faith in social institutions and social authority, and obviously a bunch of the kind of failure to address the crisis is an extreme reflection of that. I am not confident that in response to that, we are going to kind of go back to sort of some sort of, mid-century faith in public institutions and expertise. I'm not sure how we kind of put that back together, or if we can put it back together, but I think that there are a bunch of kind of factors or things going on in terms of sort of evolving social values, evolving sort of ideas about sort of social identity, particularly in a very wealthy economy and society such as ours, that make a set of these things extremely difficult. And I wish I had better answers for what to do about it, because we're kind of seeing the consequences of that now.
Well, on that happy note, at least we have this plan to help us get through this crisis. So thank you all for all that work and for the plan itself. Also, thank you for taking the time and for the great conversation. And thank you to everyone who's tuned in to listen. Really glad to have been a part of it. And I hope we can get this thing under control. I'm sure everybody else on the panel does too. So thanks again.
Absolutely. Thank you, David.
Thank you.
Thanks, everyone.
Thanks, David. Thanks, everybody.